is Tony. I'm an assistant dean in the School of Health Professions and Human Services. A warm welcome to all for being with us this evening for our State of Hope event. To begin our event, the dean of our school, Dr. Holly Syrup, will offer some opening remarks. Dean Syrup has been a fixture of leadership on Hofstra's campus for over 35 years. Dean Syrup has served in a variety of administrative leadership roles in both campus life and in academic affairs. Some of Dean Syrup's past roles include serving as the Executive Dean of Students, the Vice President for Campus Life, and then in 2006, Dean Syrup joined Hofstra's faculty by achieving a joint appointment in the departments of counseling and mental health professions and educational leadership. In 2015, Dean Syrup rejoined administrative leadership when she became the Vice Dean of the School of Health Professions and Human Services, and also achieved the rank of full professor. Since then, Dean Syrup ascended to the role of being the dean of our school, and under her tenure, the School of Health Professions and Human Services has been achieving steadily increasing enrollment growth and program expansion. Most recently, in October 2019, Dean Syrup was recognized for her lifelong career achievements in leadership as she was named one of the top 50 women in business by the Long Island Business News. It is my absolute pleasure to welcome Dean Syrup to unmute yourself and address our audience.
Thank you so much, Tony, and good afternoon, everyone, and thank you for joining us for our State of Hope virtual event. The State of Hope, Healthcare Opportunities and Policy Exchange, was created to provide an outlet for the community to come together to discuss contemporary issues in healthcare and the impact on current and future policy. Tonight's event, as Tony mentioned, is also a part of our annual National Public Health Week celebration, and with its topic focusing on reflections and implications for public health, it once again brings to the forefront important, timely, and needed discussions in health policy. The guiding theme for our 2021 National Public Health Week event series is health equity. Earlier this week, we had the pleasure of having Dr. Andrea Alt-Brutus, Director of Health Equity for Nassau County's Department of Health, who served as our keynote speaker. She shared that although there's been some renewed attention on addressing health equity since the COVID-19 pandemic, and now, of course, with the vaccine education and distribution, in order for true progress to be made, we must work together to address systemic changes. Overall, the past year has shown that public health entities need additional support. And to address the systemic changes needed to advance health equity, local community-based organizations must be supported as they play an integral role in addressing issues around health equity. Tonight's panel of speakers are all advocates and leaders for public health in their respective professions and areas of expertise. As we learn how their lived experiences, their research and advocacy continued throughout COVID-19, we will learn how the practitioners of today are trailblazing paths to improving health equity and the health of communities for all. I truly look forward to hearing tonight's discussion and would like to thank our speakers who've been so generous to share their experience, their insight, and their expertise. And now it's my honor to introduce our moderator, Kemp Hannon, Health Policy Fellow in the School of Health Professions and Human Services. Kemp joined HPHS in April 2019 after a distinguished career in the New York State Senate, where he had built a reputation for working across party lines to put the health and well-being of others in the forefront. He continues to do so by organizing and facilitating our State of Hope programs, which allows for an exchange of thought, policy, and practice. And it's now my pleasure to turn the program over to Kemp for his opening remarks and introduction of our speakers.
Welcome. Thanks very much for joining with us today. And we continue our exploration of some of the avenues of public health. Especially, we want to focus on today the pandemic, what has taken place a little bit during the pandemic, but more importantly, what have we discovered as to what we can do in the future, what we ought to do in the future, dealing with who needs to get health, how are they going to get health, where are they going to get health. You would think basic questions, but we're not here to come up with the solid answers, but try to raise the right questions. Obviously, people have been very angry as to the way government has gone about dealing with the pandemic. But interestingly, as you scan the nation and scan the globe, even if there are contrary types of policies that have been carried out, the populace is still angry. When you're not healthy, when you're ill, when there's severe death, people do get angry. So that my view of what we have to do is to overcome that anger and try to look at what type of measures can be taken as a matter of policy, both in terms of government and in terms of private healthcare, to address these questions. Joining us today are three individuals who are totally qualified to explore these pathways and byways. Dr. Debbie Salas-Lopez is the Senior Vice President of Community and Population Health for Northwell, which includes an incredible array of endeavors: community health investment, relations, strategic community partnerships, the Center for Equity of Care, smoking cessation, human trafficking. And since she joined, coming from the Lehigh Valley Health Network in the beginning of 2020, or maybe the very tail end of 2019, she had very little time on the job before the pandemic hit. And she immediately had her scope of endeavor broadened and has been, I'm sure, a 24/7 endeavor ever since then. So I'm going to ask her to speak first. And if you'd give her your attention, Dr. Lopez, the floor is yours.
Thank you very much. And thank you for the invitation to you today to speak to this group. I love the acronym HOPE and what it stands for. And of course, I love the theme of equity and social justice. So just to level set, I just have a few slides to prepared for you to provide context for COVID and what's happened during the pandemic here at Northwell Health, here in our community, here locally. But you might take this and extrapolate this across the country because it happened across the country. We were the center, the center of the epicenter here in New York. When COVID hit, I came in the tail end of 2019. We were not prepared for what we saw, we felt, and we had to deal with. Who knew that in this country we would worry about running out of oxygen or running out of respirators to take care of our patients? And that's exactly what happened. Today, we're happy to say that we've taken care of well over 100,000 patients that had COVID. We've discharged well over 50,000 patients from one of our 23 hospitals. Our workforce, healthcare heroes, doesn't do them justice in terms of what they endured, what they did, putting themselves in harm's way to save people's lives. We're on the other end of that now. What I'd like to share with you is that while we're not out of the woods by no stretch of the imagination, the system has learned how to incorporate. Today, we still have over 1,000 patients hospitalized with COVID. And so we have learned a lot about ourselves as a system in healthcare, but importantly, we've also learned a lot about our community, because what COVID did for us was show us, it put a bright light on needs that were in the community prior to COVID, and how COVID devastated these communities disproportionately, large part due to the high unmet social needs that exist and continue to exist in our communities. So let me begin there. This is a graph to show you the devastating toll COVID took across the country by race and ethnicity. This comes from the CDC, that our communities of color were disproportionately infected, hospitalized, and died by race and ethnicity. Here you'll see that in late May in late April, early May, we were looking at where our communities were that were coming into our hospitals. In particular, some of our smaller hospitals like Forest Hills and Valley Stream Hospital. And there were hard to reach communities, underserved communities. And we said, what can we do proactively? How can we go upstream to provide testing? Because if you recall, in the beginning of the pandemic, testing was at a premium. We didn't have enough tests. And so we thought, what can we do to get testing into hard to reach, underserved, poor, vulnerable communities, and also provide education? To date, I'm happy to say, we've provided testing to well over 85,000 people at over 100 community and faith-based locations in communities of color across all of our boroughs and some of our counties. This graph should not surprise you that in the Bronx, for example, the serology, the antibody prevalence in the community there was the highest, as well as Queens. And so we began to do testing both for active COVID as well as prior COVID vis-a-vis serology to ensure that we were providing our community with not only information, but also education around COVID and what they could do to protect themselves and protect the community. You may ask, why was that important? And by the way, we didn't do this alone. Full disclosure, it took a village. Our county agencies, our public health agencies, our state, our community-based organizations, our faith-based leaders, who, by the way, sometimes were the first in line to show the community that they needed the testing, that they wanted the testing, and that education was important. And in fact, the difference that it made, this is from a quote from Dr. Eliseo Perez Stable, he's the director now of the National Institute on Minority Health and Health Disparities, that said, what we did here, while hailed a public health victory, and we're not out of the woods, we're not done yet, that in fact we were able to drive down virus infection rates in our Black, Brown, and Latinx communities. What about today? Well, it turns out that the relationships that we either strengthened because they were pre-existing for us in the community, or we established because we did not have a relationship or a partnership in that community, in particular, a community hard hit by COVID, that now we could go back and ask and work and partner and collaborate with those community-based organizations around the vaccine. To do that, I think many of you know that Northwell was named the regional hub leader for Nassau and Suffolk County. And we thought, what a better way to ensure that we were providing the vaccine safely, effectively, and equitably across our hard-hit communities, but to establish a health equity task force, which I now chair. Today, we have over 100 community, faith-based, even tribal nation leaders, county and state representatives who attend meetings with us every week to talk about not only community planning and outreach, but also education and addressing vaccine hesitancy, which, as you know, exists in our communities. We have leadership forums, we have talks that we give, and we invite individuals to come and share with us as well, and with these leaders, their thoughts on the vaccine, on not only infection rates, which continue in our community, but also now going forward, how do we continue to now evolve this group into the work ahead? We're already thinking and planning for the things that lay ahead of us that are about equity, whether it's in the physical built environment or it's in the healthcare access environment. Let's continue to do this work together now that we've established these great collaborations and partnerships. How are we looking now? How are we informing our approach to vaccinations? This is a map that we use. This is only a prototype, but we are looking at not only COVID infection rates in our communities, we're also looking at social vulnerability rates. Where do we have resources in our community? Where do we have vulnerability in our community as it relates to socioeconomic status, availability of mass transit, resources, for example, where are the hospitals in our community, our federally qualified health centers, even our pharmacies? but also look at the map to the right. Where are there other community resources that heretofore we didn't engage in the space of health and health equity, our public high schools, our gymnasiums, our hospitals? And so today I'm happy to say we've vaccinated, and this slide is already old, 780,000 people as of April 4th. You can see the figures there in Nassau and Suffolk County. Our state database actually has even higher numbers. Roughly about 50% of the eligible population in Nassau and Suffolk County have now received a vaccine. But we also now track not only this by borough and also by county, we track it by location. Where are we providing, we call them pop-up events because these are one-day events where we can deliver 200 or 500 vaccines to a particular community. Again, this slide is already outdated. We are now at over 25 different community, faith-based locations, community centers where we're providing the vaccine to vulnerable communities that were hard hit. I share this picture because this is when we started. We started in January when eligible populations in the community were mandated by the state. We were allowed to do it by the state. This started on MLK Day. Grace Cathedral International is located in Uniondale, a very hard-hit community for us. And Prayer Tabernacle is located in Amityville. I share this picture because I always try to go to our pop-up events, whether they're in a community or in a faith-based location. And I was struck by, on that day, the sanctuary was used as the observation site and unit so that after the community member received the vaccine, they could sit there and be observed by us. It was wonderful to see how community-based and faith-based organizations came together. And frankly, it was pretty inspiring because here we were injecting hope in that community. We also, I'm happy to say that diversity for us and equity for us extended to all communities. This is a 101-year-old Holocaust survivor patient, that a community member that received the vaccine. And he, in fact, the team called me to let me know that this individual stood up from his wheelchair and then prayed for every single member of the team that was there on that day and by name in gratitude for what they had done for him. This is my last slide. There are many communities. This is a homebound community, our elderly community. We start an initiative next week for our homeless community. And so this work will continue. While supply for the vaccine is increasing, it's still not increasing to the level that we need given the demand and the eligibility for the vaccine. So we continue to apply not only the equity lens to it, but also think of our communities that are sometimes we don't see, like our homebound seniors who do not have technology, sometimes don't have a smartphone so that they can register for the vaccine. So we are in fact in the process of going to them. To date, we've delivered over 500 vaccines to homebound elderly individuals who can't leave the home due to a chronic illness to come get the vaccine. And so with that, I will turn it over to my colleagues. I'll stop sharing my screen so that you can continue the conversation.
Thank you very much, Doctor.
Welcome.
It really tells the story of a little bit of where we've been and reminding people that I think our biggest limitation in many ways was how many shots do we have? Right. And yet we have a number of challenges coming ahead with 50% at least getting one shot in Nassau, Suffolk, which is probably pretty high. The next question is, how do we reach people who we ought to be reaching and don't know? And second, what do we do about the folks who just don't want a shot? So those are some of the choices, maybe far better for Professor Mercado when he gets a chance, our expert on ethics. But really in terms of disparity, no one better than Professor Martine Hackett, who is an associate professor at here at Hofstra, the School of Health Professions. Her background is especially in public health. She comes with, I think, a unique set of qualifications. having worked in the New York City Department of Health and Mental Hygiene in their maternal and infant reproductive health unit. And before that, she did film and TV at NYU, Masters of Public Health at Hunter, and a doctorate in sociology at City University. So always informative, provocative, and person to listen to. Dr. Hackett, the floor is yours.
Thank you so much, Senator Hannan, and thank you everyone for being here today. Happy National Public Health Week. So I'm going to just structure my remarks sort of on the prompt that was given for this State of Hope presentation. What have we learned? What needs to be improved? And what gives me hope when it comes to public health based on the last 13 months? When it comes to thinking about what we've learned, the first thing I would say is that don't wait until to focus on racialized communities. I think what we know is that we sort of had to start to see some of the data, start to see some of the statistics around COVID cases in Nassau and Suffolk County before people started to realize, oh, maybe we should put testing sites in those communities. As was mentioned, certainly there was a scarcity of those tests in the early days, but the idea that what we have learned, should have learned, is that we don't have to wait for those statistics. We need to be able to know that these are the communities that are going to be hardest hit when it comes to issues, especially around communicable diseases. Second is, I think that we've learned how to talk about some of these health disparities or differences. One of the things that I have been happy to hear in the discourse, and also that I've been happy to respond to when asked, is when we talk about these differences within communities of color in Nassau and Suffolk County, and people ask why. I think that the discourse has been more around the idea that it's the environment, it's the living conditions, it's the jobs that people have, it's the taking public transportation. The social determinants became in the forefront of how we are talking about these differences, and not in genetic terms, although I have heard some of that. But the idea is that we have, I think one of the things that we've learned is how to talk about these health disparities in our communities. The third thing that I think that we have learned is the value of the community touch. I think Dr. Salas Lopez just talked about this very eloquently about the faith-based institutions and opening up to be pop-up vaccine locations. But I think the other thing that we've seen over the last year is the significant role that communities can have. They have that local touch. They know exactly where to find the people who are most in need and are not on the sort of official rosters. We have seen the communities be able to provide the health needs within for their community members, and we've also seen the communities provide basic needs. One of the things that I have been working on with different community-based organizations over the last year is this sort of recognition, especially around infants, people who have infants and young children, are the needs for basic things like diapers and formula. And sadly, the top two things that have been shoplifted are diapers and formula. And so I think that what this points to is that these basic needs are not something that go away, and in fact are something that are highlighted during this pandemic. But I do believe that I think that we've learned is that local communities can help to serve those needs. Another thing that I think that we've learned, of course, is that racism is a public health crisis. And I know that we've heard this term throughout the other sessions of this Hofstra's National Public Health Week, but I really do just want to sort of emphasize that not only do I think that these are words that people are using, but I think that we have seen some action behind this. As of now, there are 50 cities and 3 states that have declared racism as a public health crisis. We also know that in addition, that a bill has been introduced into Congress that is in September to be able to address this public health crisis of racism. And another thing that I think that we've seen is really the depth of what that means. For example, I don't know if you had heard that, you know, a pulse oximeter, which is helps to measure the level of oxygen in blood, which has often been used as a test to be able to see if someone has COVID. It's a machine. It's a machine that doesn't have a brain or eyes or any kind of, you know, personality, but yet it's a machine that has been found to be racist in the way that it measures the oxygen level in people who have darker colored skin. And again, how does that happen? It happens from the way that these, you know, machines are made. And so that is one of the things that I think that we've also learned is that racism is systemic. It's built into things that we think aren't people, or definitely aren't people. And it makes us realize that racism exists even if that person is not there out front. When it comes to thinking about what needs to be improved, I think about the first thing that really comes to my mind is that there are issues that sadly have not gone away during this pandemic. We have seen and are, you know, really concerned about issues obviously around job loss, economic loss, and people in precarious housing conditions. This is something that I think we know that there is an eviction moratorium that's happening right now for the most part across the country, but this is something that is of grave concern as we know that housing is uniquely connected to health outcomes. Another thing that I think that we've seen that has not gone away is gun violence. Gun violence, certainly over the last few weeks, again, has not gone away and has been addressed and seen again and again, and the hate that's associated with it, in particularly anti-Asian violence. And so I think that that's one of the things that we've learned is that even in a pandemic, there are things that have not gone away, major public health concerns that have not gone away. I think another thing that we need to recognize that we need to improve is what do we do about racism as a public health problem? I think that some of you might have heard that the Journal of American Medical Association just in the last few weeks had a bit of a controversy when there was a podcast that they released that basically said, racism doesn't exist in medicine, and an entire conversation that then went on to be able to talk about how doctors can't be racist. And this led to a lot of pushback in addition to protests. And I think that what we are recognizing is that when it comes to dealing with issues of racism and health, we kind of have to put up or shut up. It really has to come down to a matter of not just sort of using the words, but really identifying and holding people accountable for what they do, or in more cases, what they don't do. I also think that the other thing that we have learned is the significance of connecting people to services. Certainly as the pandemic, the cases were increasing and contact tracing occurred, we recognized that not only did people need to be isolated, but you know, there were problems around them isolating because of crowded living conditions. But in addition, it unroofed many different social services and social needs within that contact tracing calls. And the idea of what, you know, from what I have heard from many people who are contact tracers is that when it comes to identifying or connecting people to needs, in particular in Nassau and Suffolk County, that there was a lack of those services available. And again, this existed before COVID, but I think this is what we are realizing is that this is something that needs to be improved. And finally, thinking about where do we go from here and what gives me hope. I am hopeful in, interestingly enough, the New York State budget that was just passed. One of the items that was passed in there is funding for schools, funding for public schools, which is known as foundation aid. And why am I so, thinking that that's going to give us hope? Well, first of all, this is a formula that addresses school districts that have have more need, more children in need, then and to giving them more aid, and not just tying that to the property taxes. And this is legislation, actually a judgment that was passed over a decade ago, but had never been funded up until now. And so this is giving me hope, because what we know is that education and is the most highly correlated health indicator for health. The better education that youth can get, especially after this pandemic, the better overall their long-term health outcomes will be. And so that is giving me a sense of hope, as is some of the legislation that has passed in the Recovery Act, and the legislation that is looking hopefully for infrastructure reform. That is really talking about what we need to be able to address when we talk about dealing with these issues, with structural racism. We need to get down to the structures. And so, and often this is connected to real funding decisions that make some people unhappy or push back. But I think if we are to be honest and to be realistic about making these kinds of changes, this is the type of investment that we need.
Thank you very much, Professor. Appreciate that very much. I have to add a comment before I get into Professor Mercado. It's about the pulse oximeter. It wasn't the fact that the machine did it wrong. It was the fact that the people who invented the machine and came up with the measurement standard never really measured people who are Black. And it had the same flaw. So therefore, if you didn't have good information at the beginning, you didn't get good information at the end. It had the same flaw as a criticism of pharmaceutical trials that don't test women or don't test people young. And so that the racism comes in the presumption of not designing it well enough so that you get good results. Anyway. More things that need to be, and it's not just new, it's been talked about in the last year, but it had been, I think, 10 years ago first discovered. Our third panelist, Professor Nicholas Mercado, joins us. He is an adjunct assistant professor of health professions. He is a clinical ethicist, program manager for Northwell's Division of Medical Ethics, and also has dual faculty appointment over at the Hofstra School of Medicine, Hofstra/Northwell School of Medicine, and also an adjunct assistant professor at the School of Health Professions and Human Services. I'm trying to abbreviate those long titles. Never before have we had such ethical considerations going on. Professor Hackett just outlined some of the choices, but I was struck this morning in reading that how many people in California have vaccinations, and they're very low in terms of senior citizens. In New York, we're not as low, but we also made a choice. We would give priority to healthcare workers on the theory that we needed to make sure they were inoculated before we did the rest of the population. A choice that's imbued with ethical considerations all over. So I thought you can give us some examples and then some lessons as to where we can go from here.
Yeah, well, thank you, Senator. I really appreciate the opportunity. And, you know, I have very tough acts to follow here, following Professor Hackett and Dr. Salas Lopez. But I do want to thank also HPHS Health Professions and Human Services for this event. And I will definitely address your thoughts, Senator, but I first want to kind of give a little bit of context. And when we talk about ethics, what do we actually mean by that? And my goal for this specific part is to kind of bring the concepts of bioethics as well as the humanities to this panel and frame my reflection with these principles in mind. But before I do, I really wish that the participants in the panel, as well as our attendees, sort of engage in a silent self-reflection exercise right now. So we typically hear the words, you know, ethics and morals and morality and humanism in our everyday lives. But if I asked you specifically to reflect on where you learned your ethics, where you learned your morals or your sense of humanism, you might say that you learned it from your family. You might say that you've learned it from your friends, your religious practices, your religious leaders, your cultural practices, and maybe just your general environment. And because we have such a variety of backgrounds, the uniqueness of family systems, the sects and the subsects of religions and cultures everywhere provides such a vast diversity of opinions and perspectives, which while it promotes strengths, it also promotes a lot of complexities, which kind of leads to what you were saying, Senator, about the issues with where are our priorities and how do we decide what our priorities are. So to kind of give a little bit of foundation to make sure that we're all on the same page, when I say certain terminology, I want to make sure that we're clear. In that bioethics, the way we sort of practice it now and the way I practice it in my clinical role is really individual and patient-centric, you know, one-on-one, maybe even a group of people. And we follow these bioethics principles that sort of give us guidance on how we address a specific ethical issue in the hospital. And this includes respect for individual autonomy or the right to make one's own decisions about their body, which is somewhat seen as the overarching principle. This is something that we go by. We go by the patient first. We go what the patient says, and that's how we sort of practice right now. Sort of, but not all the time, but in most cases. And then we talk about the beneficence or the non-maleficence, basically to do good and remediate harm. And that is more along the control of the clinician. And finally, a principle that was also brought up by Professor Hackett and Dr. Salas-Lopez is that of social justice, which means the promotion of equity and the equal and the fair distribution of resources, which I think kind of during a public health crisis such as COVID-19 is actually the governing and overarching principle that we should follow, but yet sometimes gets overshadowed by individual practices. And while it's important to acknowledge that the other three principles should not be discarded completely, we have to understand that not only in addition to social justice, we also have to understand what is the utilitarian approach to try and benefit the most amount of people and try to promote goodness for the population. When I say utilitarianism, I'm talking about the doctrine that the actions are considered good or ethical based on how many people we benefit for the majority, not for the subset or the minority. And if we reflect on the issues during the COVID-19 pandemic, we could certainly think of instances very early on where we had a lot of ethical considerations, and this included quarantine measures and the stay-at-home orders, the closing of non-essential businesses, and how people were suffering and not receiving aid or not receiving stimulus from the government who is elected to protect them. We're seeing it with masking even now, even though that has been a consistent recommendation and to some extent a mandate for almost or more than a year. Contact tracing and epidemiologic surveillance, as well as the ethical issues revolving that. And we're seeing it with vaccines right now and the issues of equity and vaccine hesitancy. And wearing both my hats, my bioethics hat and my public health hat, I can appreciate the conflict that occurs with the public health system has to step in and implement a directive that is likely going to restrict civil liberties or at first may result in inequities. But in my view, the public health system and the amazing practitioners that keep the public health system running are usually not in the business of implementing measures for the sole purpose of restricting individual liberties. But as you indicated before, Senator, we can't please everybody. We do our best to try and implement a measure, and we have we hear what the community is saying, we hear what the public is saying, we alter it, and then we still hear what the community is saying, and we still have people who are angry. And there are the inequities that were outlined in Professor Hackett's reflection suggests that we can't, this isn't a one-on-one issue. This is something that has to be addressed on a more global scale, but that includes involving the people early. That includes being proactive in our engagement and not just waiting for things to get at their worst or waiting for the statistics to come out to say, yes, this population was hit very hard, let's now intervene. It's how could we have anticipated this in a much more proactive fashion? And when it comes to any sort of public health measure, there are 5 justificatory conditions that we have to meet before we implement a measure. And that's, is the public health intervention going to be effective? What is the proportionality, the risk-benefit analysis of this? Are the risks of the measure going to outweigh the benefits? Then we shouldn't do it. If the benefits are going to outweigh the risks, of course, we should at least consider moving forward. Is it needed? So what is the necessity? Does it involve the least amount of infringement on individuals? And public justification and engagement, which is the 5th one, and I think the most important one. So as I look at the public health system and its practitioners, I see them as the true promoters of wellness and good health. Is it perfect? Of course not. But as we peel away the layers of each public health decision that we've made over the last year, we start to notice how complex each decision can be and how different individuals respond to it. As I said, we saw it with masks, we saw it with stay-at-home orders, we're seeing it now with the vaccines. And as I sort of think to the future, and as I started hearing about these passports, the Excelsior passports that one can get on their phone showing that they have immunity, I start thinking to myself, is this really going to increase voluntary uptake of the COVID vaccine so that we can, say, get back to normal? Or is it going to further exacerbate some of the inequities that we have already seen with the COVID-19 pandemic and as well as our subsequent responses to it? As I have learned, there is no right or wrong. There is no good or bad or yes or no answer. And if there was, it wouldn't be an ethical issue. We wouldn't have to have these difficult discussions. But that doesn't mean that just because it's difficult or we receive pushback for wanting to redistribute money from other healthcare budgets to public health infrastructure because it roughly gets, 3%, maybe less of the general expenditure on health. It doesn't mean that we can't stop trying to achieve health equity. But as I sort of heard what you said about what happened in California, Senator, versus what happened in New York, it's really about, as was said before, is any decision that we make, any algorithm we create is going to be just as good as the person or people who create it, biases and all. And that includes us being aware, being able to discern when those biases are showing so that we can address them and we can be proactive before it gets so bad that we start fostering more mistrust in the community that has already been there. So that's my reflection for this beginning, and I'm very excited to have a further conversation.
Thanks. Well, we did, one of the things was noted that we have lots more money there. And I think lots of the money comes on the federal level to, and it's going to go through the state also, to encourage vaccination. I think we have a choice, and I don't know which way that I would go. So that's great that we have 3 wise heads here. Should we spend all the money chasing down people who are reluctant to get vaccinated, to persuade those who need to get vaccinated? Or should we look out for the highways and byways? One of the slides that Dr. Lopez had was a story in the New York Times about going to senior citizens' homes and seeing if they want, when they want a shot, going to them because they can't get to some type of location. So I don't know, where would you put your emphasis? Persuading, delivering? We still have 50% of the population that don't have shots. And this morning's statistics in the Times show that there's, in the United States, a 19% increase in cases over the last 2 weeks. So we're not over anything yet. Dr. Lopez.
No, we're not. I was very interested in both Professor Hackett and Mercado in this, what they shared, their thoughts and what they shared. I just want to talk a little bit about the importance Professor Mercado, of the community touch and how important relationships are. And COVID showed us that we, the healthcare system, the public healthcare system, can't go at it alone, but we can go at it in partnership with community leaders and faith-based leaders. And that in and of itself makes a difference, particularly as we move forward in providing education and outreach so that people can make informed decisions. And then, of course, Professor Mercado, I hadn't thought about it in the light that you just shared. And the 5 points that you shared in terms of, is it a public necessity? Is there a great need? Are we doing it with the least infringement? And so I would check mark for all of those, because the imperative here is we have seen the death toll. It's unimaginable. We had hospitals where we brought in trailers to accommodate the mortuary and the death rates, because it was just impossible for the infrastructure to contain how many people were dying. And so for us, it was a very real, we saw it firsthand, not just in the news, but we experienced it. I'll be honest with you. I think that it's a both and to your question. Do we focus on delivery, or do we focus on, education? Today's supply, it's still the rate limiting step. And so we've got to think about that. We are working arduously with the Health Equity Task Force to provide culturally, language, and literacy appropriate information to our community. With their support, with community leaders and faith-based leaders. So that's important. So that when we do have enough supply for everyone who's eligible to come in and get vaccinated, there's information available and education available that they can consume to make a decision. The delivery isn't easy. The case that you talked about, homebound elderly. When we open one vaccine box, we have a certain number of hours to use it in. And that's mandated, by the way, by the state, not to have any waste with the vaccine. And so imagine if we're going into one person's home, we have to have at least 4 other homes lined up in that geography so that we can be efficient and effective, so that we can deliver the vaccine within a certain number of hours we have. So the delivery is complex, particularly for the homebound. And then look at the homeless community today. We've had to ask for special dispensation for the homeless community because the requirement to get vaccinated includes a photo ID, includes a home address, includes an email address, because we've got to report all of this to the CDC and the state. So we've had to ask for special dispensation because in the homeless community, our homeless community oftentimes don't have any of that. And so I think we're doing both, focusing on the delivery, focusing on education and a vaccine hesitancy and all of that. And I do think that the rate limiting step today is still supply.
Professor Hackett?
I think the investment really does need to be within communities, as we've seen has been a fundamental component to improving both testing and vaccines. And so I think that this is a perfect opportunity to sort of put your money where your mouth is. What we talk about with this investment within communities and not just popping in as needed and then, leaving. A real testament to that would be investment in community resources to be able to have physical spaces, to be able to have funding for additional needs as they come up. I think, that kind of investment, if not now, I really don't know when, to be able to recognize that this is not just an investment, but this really is something that will pay off later in the following, issues that we are definitely going to have. And so this is not wasted, and it really is a matter of investment. I would also say just one other thing, just in terms of thinking about this idea of data and data collection, and just something that can be done that really doesn't cost anything is collecting data by race, ethnicity. Again, you think that this is something that is just, oh, everybody does this, but we know, again, even before COVID, to be able to collect race, ethnicity data was often missing in many cases, or not identified by the patient. And that's, even though we can look at statistics today for vaccines and for testing, and even for death, we know that there is significant data that are missing around race, ethnicity. So again, that's something that can be certainly improved.
Yeah, they basically only use zip codes. They don't use actual identification, which is, so there is a correlation which is not necessarily justified. Professor Mercado.
Yeah, Dr. Lopez, I remember, seeing those trucks, those trailers outside because our morgues were full. I remember sitting, and to some point, this was around the time when I was sitting on a system committee to try and help the frontline workers with these very difficult decisions. And, I have wonderful colleagues in this, in this endeavor to try and assist with all of these true ethical dilemmas out here with not only with the patients and the patient care, but also sort of thinking more broadly of, okay, are we going to have another episode of having short memories, before we have to handle a situation similar to this again? So I certainly do recall how difficult it was back then. And we are, again, I agree with you, we are by no means over the hump. But I kind of want to, look at this from, as Dr. Hackett said, very hopeful message that if we acknowledge what mistakes we have made and how we can go forward by engaging with the people who were affected, by engaging not just with the thought leaders and the people who are, on the higher up, but also the community leaders, whether they be religious leaders, whether they just be the person whom a lot of the people trust to deliver that message, and not just be the guns blazing kind of people that a lot of the authoritarian way of looking at things. We have a lot of opportunity to engage and be proactive and prevent. And one of the biggest aspects of public health is investing in an infrastructure, hoping you never have to need it. But if you do need it, it's there. And we didn't have that. We didn't have it at the federal level, and we didn't have it at the state level, and at the county level as well. So the ultimate testament to what we're doing now, and how your department and the offices and programs that you oversee are trying to engage communities and bring it to them, while also taking steps to try and educate. I feel we have a sort of moral obligation to, just because somebody says, I don't want it now, doesn't mean that we shouldn't still involve them in the conversation. And it also doesn't mean that, again, because it's difficult, or because we are receiving pushback, or, we have to engage in a dialogue. And that dialogue has been silent for quite some time.
I just have a reaction for Professor Mercado. So thank you for, and Professor Hackett, you both pointed out the need for investment and for infrastructure development. And you're right. I think you were closer to it in terms of where the morgue was in terms of deaths, and how we were not ill prepared. We were, and the other thing that this pointed out to us is not only the importance of public health, the importance of social justice and equity, and looking at things in our community that oftentimes we've normalized or we're blind to. As an example, we know where there are communities where there are healthcare deserts. Well, during the COVID testing days, and where COVID hit, they were really hard hit. And now with the vaccine, we're looking at the data and saying, where are the resources in that community? There's not even a CVS or a Walgreens or a pharmacy or there's not even a food store with healthy foods. And so we're now applying that lens for all the things that make a community healthy and well, and give us, we're looking at communities now by zip code in terms of life expectancy, and looking at the differences with adjacent zip codes. and how different it can be in terms of life expectancy for a community member that lives in a particular zip code. But you said something very important, and that is, I honestly don't know if we would have ever imagined this was possible. That a pandemic of this breath and death, could take so many lives, and then we would find ourselves in the predicament we found ourselves in. What we did learn was how to work together, how to partner. We were helping each other out as a community, as a health system. We were calling our health system competitors to see how we could help them, and they were calling us to see how we could help them. We went to Georgia and Texas and Intermountain to Utah to help the nurses as the pandemic went through the country, state by state. So we did learn one thing, that in spite of all of the things that we might have established and had ready in the community, that when the unimaginable happens, if we rally together, we can do anything we put our minds to. And so that was, I think, a good takeaway for us.
One of the things I'd like to kind of amplify is something that Professor Hackett said in terms of going into the community. And it's part of a theme that's been somewhat stated in different ways, but not really made a major point. And that is not necessarily looking at what we have to do or where we have to do it, but rather how we have to do it. We're still looking at the approach to health in terms of institutions. And yet we know that we're talking about visiting homes, difficulties with that. When we had a prior forum for Hofstra Forum, we did telehealth. And we had Dr. Dorfler from Northwell tell us about how, and it wasn't amplified, how the telehealth program exploded in terms of magnitude and also got somewhat married with the home health program at Northwell. Not necessarily that that's been totally ratified and something to explore, but last week I saw President Biden propose in his jobs program $400 billion for taking care of the elderly and emphasize doing it at home, which especially in light of the criticism of nursing homes during the pandemic is something we're going to have to explore. So, and also the access to it. Do you have to have a hospital? Do you have to have a clinic? Do you have to have a FQHC in order to try to get healthcare? Why not something that would be far more available to the community and therefore overcome what you just said, Dr. Lopez, about the health deserts? And it's a question of delivery and making that more of an emphasis and point. And I don't know what your comments on that. I don't know if you think it's practical or not, Professor Hackett.
I think it requires just a rethinking of how we deliver healthcare. I mean, I think, and what does that mean, right? And I think that we're talking about public health. And as Nick mentioned, we are talking about prevention, but as you mentioned, Senator, it's the how do we do it? And I think one of the things that, again, is not new, this is not like cutting edge, but community health workers are a very proven approach to be able to have people from the community trained so that they are able to be that linkage to people who need help within the community. They speak their languages, they understand their cultures and customs, and they are trained to be able to provide that information and linkages to other institutions as needed. I think that, again, this is not something that is, no one's ever heard of before, but in fact has been found to have significant improvements, because not only are you just making those connections, but it's literally the connections that you are making with people, right? To have people have that social support that also has an added benefit. And so I think that, in part, what about investing in that? What about investing in that training? What about investing in that type of infrastructure so that you're not taking, physicians who are trained for 12 years and putting them in those communities? You're taking people within the communities who are looking to build their job skills, who are looking for an approach to be able to help people within their communities and pay them for it. And so I think that for example, is a type of approach that could easily be implemented.
Well, in this state, not only have we shortchanged public health in the terms of the counties, When it came to arranging for tests and then for vaccinations, the state decided to bypass the counties entirely, which I'm not so sure is all that great. But even yesterday, County Executive Curran announced home visits in Nassau, but instead of using the public health nurses, she's using police department medics, which left me scratching my head. So all well and good to do it, but how to do it is again the question. Dr. Mercado?
Yeah, I really enjoy it because, you know, Martine, it really makes me feel like I'm back in your class about learning about some of these, you know, concepts about, you know, engaging the community in such a fruitful way. But again, in my view, it's again being the proactive, not waiting until these things get so bad, investing in the community health worker, the community health workforce, giving them money so that people want to enter the community health workforce, to try and also recruiting within those communities to try and, again, not only build that relationship, but also foster that relationship, increasing the workforce, increasing the trust within those communities, and really giving us the opportunity to work with the trusted people within those communities to, again, not have a physician from a high, you know, nothing against my physician colleague, but not to have that person come in thinking that they know it all, knowing nothing about that community, what they value, what is important to them, what are their customs. Is there a cultural or religious reason why there is vaccine hesitancy? Is there something that is giving much more weight to the decision making than just what we're hearing from the CDC or what we're hearing from the public health authorities, because that's how it's seen, the authorities. And that really it's about not only just speaking the language in the truest sense, but also speaking the language that from the people whose opinions they value. And I think we miss an opportunity every day that we don't invest in it, not simply because we're in a crisis state, but also when we're not. And again, I don't want us to have the short memories thinking that, you know, we may not have a pandemic to this magnitude for the next 75 to 100 years, but we will have public health crises in which that investment could definitely pay off in the long run.
Dr. Lopez, any sense of why there is the hesitancy, the reluctance, the hurdles to overcome?
Yeah, so there's a historical perspective here in terms of hesitancy and mistrust of the medical system from in general. You know, there are, particularly in our communities of color, you know, our Latinx community, if you look at history and look at what happened between 1930 and 1970, and the unwitting sterilization of women in their reproductive years. If you look at what happened to the Black and Brown community over the years, and what's happened in Tuskegee, which is the one that comes to mind. Even the tribal nation community, I've been working closely with them, and what they experienced in terms of warm blankets that were given with laced with pathogens. So there's a reason, there's history here, while there's general mistrust. There's also, you know, misinformation regarding how fast the vaccine was produced and was it done safely, who was in the clinical trial. So there are many reasons. There's lack of information. You know, when I talked about the digital divide, where many communities don't have access to information the way, you know, we say, go to a CDC website. What does that mean to some of our communities who are struggling today, do not have the data plan or the Wi-Fi or the access to get to you know, an iPad or a computer to look for information in ways that make sense to them. So there are many reasons why there would be vaccine hesitancy. I will tell you that we're in the community now. We're providing education and information around the vaccine. And yes, while there will be communities that don't want the vaccine even after getting the information, that you know, communities, by the way, of all diversities, there is an even bigger community that is is getting the information and is willing to take the vaccine and receive the vaccine. And for the millions and millions and millions and millions of doses that today have been given out worldwide, we're tracking to see what the untoward effects might be, at least in the short term of the vaccine. The risk of dying from COVID, back to the risk and benefit that I think Professor Mercado was talking about. The risk of dying from COVID is much higher than the risk of taking the vaccine. So I'll end there. But I do want to get back to something that was said previously regarding community engagement and what we're doing. We learned the following, and this was between testing and between now the vaccine, that unless you're going into the community prepared to listen, because for all the data that we have, there's some data that frankly the community doesn't care about. You know, as an example, our operators here and our senior administrators, particularly during COVID, wanted to make sure that only people that really needed to be in the emergency rooms came to the emergency room. So, you know, for where you have a healthcare desert, sometimes our community uses our emergency room for what we call ambulatory sensitive conditions. When we did our community listening tours, the community was either unaware that that was something that we tracked and followed, or frankly didn't care. What are they worried about? They're worried about their youth, the future, education of the youth, employment of the youth, pipeline programs. They're worried about mental health and wellness in the community. You know, it has anxiety and depression and social isolation, all the things that have been, dare I say, an unintended consequence of COVID is ravishing our communities. And so when you think about, you know, what do we need? It could be, at the risk of solution jumping, it could be community health workers. It has been established that they're effective within the community. But, you know, back to the point you made, why would we use policemen? In Suffolk County, they're using paramedics to go in and do vaccinations. Well, I'll tell you, the other side of that is, you know, we have to think creatively about who does what in our community and how can our community, in schools at Morehouse in Georgia, they're using high school students to be community health ambassadors. And you know what their charge is? Let them learn about education, how to take a blood pressure. And they're going home to do that with their families, and they're identifying high blood pressure rates in their grandmoms and their moms, and potentially preventing strokes. So we do have to think disruptively and creatively and innovatively about who does what in our community. In the UK, as an example, when the postman started to see fewer and fewer need for delivery of mail, you know what they started to do? They started to walk the elderly, those that live alone. They spent half an hour walking with the elderly around the block, and that became part of their responsibility. So I think that it's not only community health workers, which we know are effective in the community. I think it's all of us, whether it's a high school student or a paramedic, and what we do to take care of each other and make sure that our communities stay healthy and well going forward.
Wow. Now we should, unfortunately, I have more questions down here to ask each of you than we have time for all day. And this has been terrific. So I'm thinking of asking for some final thoughts. And I would start with you, Professor Mercado, and then I'll go to Professor Hackett and then Dr. Lopez.
Yes, thank you, Senator. I really appreciate the opportunity to serve on this panel and with the great minds, as you had mentioned, to kind of share some thoughts and reflections. I think if I were to really think about how I would want to use my self-proclaimed expertise in this area, it's really to be a resource. It's to be a resource to people who feel that they can learn to trust again. And I really think that that's a really big barrier. I really think that if we are not being interdisciplinary in our way of addressing issues of mistrust, if we're not and that includes the people in the community. It doesn't just include the professionals, the healthcare professionals, such as public health professionals, medical professionals, and spiritual guidance and spiritual health professionals. But unless we start to look at this from the multiple different lenses, very similar to how this panel was structured, from the multiple different lenses so that we can learn from each other, I think we're going to start noticing the further challenges we're going to have addressing not only this current crisis, but also future crises. I'd also lend a thought about, and then again, kind of shifting back to my bioethics hat, it's really engaging and having a conversation about what other people interpret and how their values are impacting their view of the current situation. As was said before, there's data that people just do not care about. I don't care what the prevalence is. I don't care what the incidence or the odds ratio is. I don't care about any of that. Can I see my grandmother again? Can I go with my kids to the park? Is it safe for me to just hang out at home with my dog? There are many other questions that we think are superficial, that are not important to answer, but will mean the world to a whole host of people. And even though we have to think about it from a population health standpoint in mind, don't forget the individuals make up the population. And there are some things that we can certainly do right now and prepare for right now to look towards the future as we get over this hump, because we will get over it.
Thank you, Professor. Professor Hackett?
Yeah, so I think that, as we imagine getting over this hump, I think we have to, bring our lessons with us. And I think that one of the things that it makes me think about is recognizing what the limits of public health have been over this past year. We have seen politics get involved in not only the distribution of public health recommendations and, sort of intersecting with facts and science, but we've also seen the way that, these messages are interpreted be influenced by things that include a distrust of experts. And so I think that all of those things need to be a real wake-up call for public health. We need to recognize that we cannot sort of just rest on our degrees and just science alone. As Nick mentioned, you really do have to be able to meet people where they are when it comes to whether it's their resistance, their distrust, or, just the questions that they might have. And I think public health really needs to sort of have a reckoning with itself when it comes to that, because sadly, even though we've had a change in administration, this is still happening when it comes to the messages from the CDC and other, concerns. I also think that public health, just thinking about it broadly as a discipline and an approach, really needs to sort of also go back to some of its roots in terms of thinking about social justice, in terms of thinking about the way that we can address those larger needs. One of the things that we recognize beyond all of these things that we have been talking about is that socioeconomic status and poverty really are at the root of many of these different health conditions. And guess what? It's been that way for hundreds and hundreds of years. And so for us to be able to stop, not stop, looking at the data, that's very important, but to, in addition, recognize that we need to bring with us that past history of public health is absolutely necessary. And finally, I would say, just thinking about, we are in Long Island, we are focused on, a lot of the issues around Nassau and Suffolk. We also have to think about what does that look like in, these suburban areas. And I would argue that it has its some unique abilities here. And I think thinking about, we know that people are moving to the suburbs because it's healthier than, leaving New York City to be able to do that. I think we also have to recognize that we have an obligation to be able to keep all of our residents healthy in a way that is more holistic and that recognizes that we need to meet people where they are.
Dr. Lopez, some thoughts?
Thank you. So I'm going to pick up on the theme of equity and social justice and public health. And the COVID taught us, so much about our blind spots, about the things that we looked away from, and how connected we are. The whole world is connected, And so I heard a quote that was really around, I don't know who to attribute to, but it was Dr. Hrabowski, who is the president of the University of Baltimore, Baltimore County in Maryland. And he said the following, which struck me. So I want to speak to each of you that's listening in on a personal level as it relates to equity and social justice and unconscious biases that we may have. He said the following. He said, be careful of your thoughts because it becomes your words. Be careful of your words because it becomes your habits. Be careful of your habits because it becomes your character. Be careful of your character because it becomes our destiny. This conference, this event is called Hope. Hope is truly critical for us to come on the other side of this pandemic and to frankly thrive in the future. This won't be the only pandemic. There's other pandemics, the pandemic of racism. And so I do leave you with hope and optimism. I urge you to move beyond words to action. Action around equity and social justice. This is our time. Thank you.
You know, that you're terrific. You've been great. I hope everybody can truly appreciate all of your very deep thoughts. I'm not going to try to add my own thoughts. I've been involved in all of this for a long time, sometimes successfully, sometimes not. There are two little chat notes in here that are kind of commercials from our listeners, and I just would mention them. One is from the WIC program run at NUMIC by Y. Hins at numic.edu for people who need WIC services. And the other is from Nahid Khan, who is a grant director at Nassau Community College for community health workers. So both of which as commercials, I think it would be most appropriate. With that, I thank you for your very precious time, your very precious thoughts. I thank all of our listeners for joining with us today, and I wish you a good day.